diagnosis of the posterior capsular tear. Inevitably, as cataract surgeons, all of us are bound to experience posterior capsular tear, and let me share you some of the tips on how to diagnose early. It can happen during any stage of cataract surgery. So, when to suspect a PC tear with an overlying nucleus? It is almost a half the battle won when you diagnose the PC tear at very early stage, because you're going to prevent the nucleus drop, rupture of the anterior-hyaloid and vitreous disturbance and prolapse. Then it also prevents PC tear enlargement, collateral damage to the other ocular structures like iris, cornea and retina. Finally, when we have effectively managed PC tear, then we have a high chance of implanting the IOL. So in this case, just viscoelastic is filled in the anterior chamber. You can see the PC dehiscence. A small replay here. And in this case, irrigating BSS, there is this pupillary snap sign. Both the cases underwent vitrectomy and they were managed with IOL implantation. Here, the radial rhexis with a wraparound tear where the PC has been torn, and beginner's dilemma of a small rhexis and difficult nuclear rotation. When it comes to nucleus management, it can also happen. This is the beginning stages of epinucleus removal, and you can see the nucleus tilting and trying to get inside. Fragment is at a deeper plane and disappears underneath the rhexis margin. Here followability is poor. Why? Because the vitreous is clogging the phaco-tip. So the nucleus does not move towards the phaco-tip at all. Here there is sudden enlargement of the red glow. Bright, unusual red reflex, a sudden feeling of giving away or pop, sudden deepening of the anterior chamber. To summarize, the important signs are nucleus tilting, poor followability, enhanced red glow, sudden deepening of the anterior chamber. Coming to the next critical important step of discussing PC tear with nucleus in situ is, why does the nucleus drop? When there is a large PC tear with an overlying big nucleus with a positive hydrostatic pressure which is seen in phacoemulsification, there is no way or no place for the nucleus to disappear. It goes into the vitreous. This all depends on the physical state of the vitreous as well. Sometimes we notice that when the vitreous is in a gel form, as in younger patients, it stays in place, but in elderly and very old patients, it has a tendency to sink. Sometimes vitreous also has a role of a third hand helping the surgeon. So surgical objectives are something very similar to how a pilot lands a plane with some snag. The 5 things to do are: diagnose the posterior capsular tear at the earliest, avoid panic and don't remove the handpiece, inflame the anterior chamber with a viscoelastic before removing the handpiece, reassess the situation, and based on the skill and experience, you can proceed towards phacoemulsification, or you can convert to small incision cataract surgery. Here, all the steps have gone smoothly. Hydrodissection, nucleus rotation, everything has happened very well. As we can see, the rotation of the nucleus is easy. Each of the fragments are being, the sculpt is being done. The stop and chop technique is being carried out here. So the lateral separation is done here. Each of the heminucleus is further fragmented. As is seen, the nucleus is of grade 2 density. When the penultimate fragment is being chewed, we can see suddenly there is a PC tear because the power is delivered is excess, or maybe the chopper was at a deeper plane than usual. So here, before removing the handpiece, the mistake was the handpiece was removed before the OVD was injected. That is not to be done. Each of the fragments are brought to an anterior level. Almost in the anterior chamber, the phaco is being carried out. Always dispersive OVD has to be used tamponade the vitreous so that the vitreous does not keep on percolating into the anterior chamber. Limited anterior vitrectomy is being carried out here. Once the nucleus fragments are removed, the cortex is removed using the same or vitrectomy cutter, or you can use the bimanual irrigation aspiration as is being done here. So as we can see, there is a V-shaped tear running between 9 o'clock to around 7 o'clock hour. Be sure that the vitreous is not there in the anterior chamber or within the bag whenever you are implanting the IOL. This is usually done by confirming using intraoperative triamcinolone acetonide diluted 1:4. Now the chosen IOL is implanted in the bag. So the last step is to remove the residual vitreous and also the viscoelastic which is used in excess here to protect the endothelium and as with the bag. Coming to the second case, this is an intumescent mature cataract. As we can see, the nucleus is around grade 4 density here. Direct chop has been done, and just when the first fragment has been removed, you see that there is a glaring red glow seen, and obviously there is a large PC tear just at the beginning of the nucleus management. The other eye examination had revealed that this is a patient who had posterior polar cataract. So intraoperatively, I was sure that the anterior highlight was not breached, so I went ahead again in this case with phacoemulsification. Each of the nucleus is brought to the anterior chamber and managed. This is critical because you can't go at a deeper plane when there is a total lack of posterior capsule. You have to use copious viscoelastic to protect the endothelium and tamponade the vitreous down. So until this stage, there is no disturbance of the vitreous, and the vitreous itself is acting like a third hand trying to hold the nucleus up. This is an young patient. The vitreous is obviously in a gel form and there is no disturbance of the vitreous. So the cutter is being used to remove the cortex from within the bag. Invariably, these cases are going to consume a lot of surgical time. You have to be mentally prepared for these cases where the time consumed for each case is going to be longer. So each of the steps have to be taken meticulously and managed carefully. The cortex removal is being done. So I noticed at the very last stage of cortex removal that there is probably disturbance of the vitreous. I used triamcinolone acetonide again here with the diluted 1:4 concentration. I identify that the vitreous is disturbed. It is a tad bit difficult to identify vitreous disturbance when you have used in excess viscoelastics, but with little bit of clinical surgical experience it is easier to identify, and as such triamcinolone acetonide is a great tool to identify vitreous disturbance. That was the final picture after the IOL implantation. Coming to the last case, this is a deep AC. Here we can see that a gentle hydrodissection is being carried out. Just when the first step of phaco is being begun, you see that the nucleus starts to tilt. So in this situation, when the entire nucleus is within the bag and it is trying to go down, you have no other option but to convert it to small incision cataract surgery. So either you have a choice of shifting to the superior area, or you can convert your temporal phaco incision as a small incision and do removal of the nucleus through the scleral tunnel wound. So brought out. Limited anterior vitrectomy is carried out, and let me skip these few steps and see. Generally, the vitreous has a tendency, it shows a tendency to prolapse towards the main node, and that is where you need to be meticulous about your anterior vitrectomy. A multi-piece IOL is being implanted in the sulcus with the optic capture. So optic capture generally ensures long-term stability of the IOL. In the post-op, the patient was finally doing well. Ovalization of the rhexis margin indicates optic capture, and this is the fastest. Setup, we need to have setup of all vitrectomy cutter, triamcinolone, acetonide. You have to have a thorough drill of all the steps that has to be undertaken for vitrectomy. Never go fishing for the nucleus because it can cause giant retinal tears and retinal detachment. And finally, being mentally prepared for this stressful situation is very necessary to handle with calm and composure. Thank you. I'll go ahead with my next presentation. So this is a talk on how to convert from phaco to SICS, when and what is the situation you are going to convert. So probable helping hand for a phaco surgeon is small incision cataract surgery. When do we convert? Whenever there is the rhexis which has gone radial, there is a PC tear, there is an impending nucleus drop and a loose bag or zonules. My concern when I am shifting from phaco to small incision cataract surgery is augmenting the anesthesia because the patient has to sit for a long haul. How do we augment the anesthesia? 1.5 ml of xylocaine is injected into the area where you are going to give the, where you are planning to do the small incision tunnel. The scleral tunnel construction has to be done depending on the site, whether you want to neutralize the pre-existing astigmatism and the surgeon's comfort level. Shifting to the superior side, you are always worried that there is a side port which is sitting at the superior side, but don't be afraid because when you create a self-sealing sclerocorneal tunnel, it is never going to coincide with your side port incision. It has to be seen that the globe is pressurized with viscoelastic because hypotony could make things difficult for you. Generally plan the incision in size such a way that the entire nucleus is going to come without any difficulty, without causing any trauma to the endothelium. We need to confirm the plane and width of the sclerocorneal tunnel incision. Rhexis enlargement is critical because when we have done phacoemulsification, a small rhexis would be there and we need to enlarge the rhexis. Bimanual wheeling out of the nucleus is an easier technique to bring the nucleus out into the anterior chamber. Coming to the first case here, as you can see there is a small nucleus fragment onto the right hand side which tends to shift away from the view. As we replay this video, we can see that it is trying to sink inside the vitreous. Immediately I shift to the superior side. A sclerocorneal tunnel is planned here, and this tunnel is around 6.5 millimeters in size. Viscoelastic is injected to protect the endothelium and also to tamponade the vitreous so that the vitreous does not start to prolapse. The rhexis is enlarged here so that easily all the fragments come out. As we notice, the fragment which had just got underneath the iris has reappeared back, and that is because of the difference in the pressure gradient inside the anterior chamber. The limited anterior vitrectomy is being carried out here. A sulcus placement of a PMMA lens is being done here. The final stages of vitrectomy is done because even at the end of the surgery, sometimes small vitreous strands come to the anterior chamber. This is a case of a Morgagnian cataract in an elderly lady patient. And here we see it is always difficult to get a rhexis in these patients, and this has shown a tendency to extend towards the equator and has gone towards the posterior capsule. The first initial step of phaco itself, I realized that everything is not going good with this surgery. So the immediate thing is you have to stop, take time to think what is the next step, logical step, and what is the safe thing to do for the surgeon is to convert this surgery into small incision. There is no heroism into continuing with phaco and causing a nucleus drop. At every stage we need to think and see whether this is the best possible step. And here sclerocorneal tunnel is being fashioned. The nucleus is small. Time. Yeah. Just within 2 minutes I'm finished. So these are the similar repetitive steps where again you have done a vitrectomy, the IOL is put into the sulcus, and finally the post-op outcomes are satisfactory. With this, I think I shall conclude and invite the next speaker, Dr. Deepak Meghur, on stage.
No, Dr. Rohit Om Prakash is, he'll be coming late, so I'll be speaking. So I'll be speaking on whether it is possible to prevent PC tear and the anterior rupture. See, I just like to remind here that these two are different entities. Posterior capsular tear and anterior rupture are independent entities. That's what I'd like to highlight to this short presentation. So this is a case where I'm in the last fragment. I already know that the PC tear has happened, and because of the shape is irregular, I thought the anterior is also ruptured. Now watch very closely what happens here. So now there is something like a small bomb which is blasting us. No, actually there was no anterior rupture then. When you AC shallowed, it causes the anterior to rupture. Again you can see, the second wave is the one which is causing an anterior rupture. So it gives us enough time to stop it at just anterior posterior capsular tear itself, and if we are alert enough, we can prevent the anterior rupture. So these are two independent entities one has to remember. So this is what is the basic message which I want to give it to you. Now this is a posterior polar cataract, and I have noticed a posterior capsular tear here. And at every stage we are all taught that we need to maintain the chamber, and the best way to do is to use any viscoelastic dispersive OVD is the best. And I am trying to visco-dissect using the dispersive OVD itself, and as careful as possible you are trying to remove all the lens matter. The principle is never allow the chamber to shallow. The only secret is you need to go as slow as you can. You can see that the posterior capsular tear it's staring at me, but still you'll be successful in preventing the anterior rupture if you can follow these basic steps. So I'm using sodium hyaluronate to create space within the bag now, and then I'm going to implant the lens into the bag itself with an open PC, and with a very low bottle height you can even remove the OED from behind the lens. The only secret is never allow the chamber to shallow, and you have visual outcomes which are almost indistinguishable from a routine one. This is another case where you have a post-occlusion search, and you can see that the posterior capsule is torn. The only thing which you have to do before doing anything else is never allow the chamber to shallow. That is the secret here. So what you do is, before removing out, you just have to, because this is a posterior capsule rhexis, because of the round thing, it's unlikely to enlarge, but we don't want the anterior to rupture. The same principle, don't come out just like that in panic. If you come out, then you lose the opportunity of preventing the anterior rupture. So if you want to remove cortex, dry aspiration is a good way to do it, but technically sometimes it may be a problem because the cannula gets blocked. You can use fluid as well, IEA, but use it very low bottle height. The secret is bring down the bottle height to as low as you can, and you'll be surprised that if you can control the turbulence, even with the fluid going in, you can prevent the anterior rupture. And if you follow these basic principles, most often than not, you can prevent the anterior rupture happening in spite of having an open posterior capsule. So that should be the take-home message here. The only secret would be, maintain the chamber equilibrium well. So I think I'll just skip the couple of cases because we'll be running out of time. So I'd just like to conclude by summarizing this basic principles which I want everyone to understand here. So anterior need not be ruptured whenever there is a posterior capsular tear, okay? It can be intact. These are two independent entities. Anterior appears like an invisible membrane. We see it only when it ruptures. It appears like a round hole as you saw there. So remember here, both are independent entities, and in a substantial number of cases, if you are very alert, you can prevent the anterior rupture. So what do you do to achieve this? How can we, apart from diagnosing it early? So one probably most important thing is always, the secret is you have to maintain the chamber. The secret is in the chamber. So never allow the chamber to either suddenly deepen or suddenly shallow. Both are equivalent. The secret is equilibrium has to be maintained. So prevent sudden deepening and sudden shallowing. Now how do you prevent deepening, So avoid having a very high infusion pressure, lower than the bottle height. Then adjust your parameters to ensure that the chamber doesn't shallow. The second weapon we have is the dispersive OVD. This acts like a barrier, and this prevents, it compartmentalizes, and it also prevents the gush of the fluid going across beyond it, and this will prevent the anterior bearing the brunt. And if you're careful with these situations, most often than not, you can prevent the anterior rupture. You can just note down the questions. At the end, we can take question answers. And moving on to my second topic here. So, Dr. Vasavada has very beautifully demonstrated that, by going through the pars plana way, we can prevent the enlargement of the posterior capsular tear. It is technically not so difficult, but when you're doing surgery under topical anesthesia, sometimes, what happens, it becomes a little bit cumbersome for us to, again, give a block, enhance, or do this, but you have to do it. But my idea is, can we achieve the same goal by going through the limbal approach itself? And if so, what are the principles we need to apply? So how can we achieve the same advantages? Again, the first, principle is not going to change. You will always have to maintain the chamber. And using a dispersive OVD, which has a contractant sulfate and hyaluron combination. Second, which is often missed upon, is the bottle height. So you're operating, when you're doing phacoemulsification, the bottle height is set at 90 centimeters. And when you start doing vitrectomy, you again keep it at that only. That is one which is going to cause us a lot of problem. So watch out for the infusion pressure. Sudden raise in the infusion pressure in a deep chamber where it has become unicameral, that is going to blow out the posterior capsule. And third important principle is try to position your vitrector such a way that the principle here what we are following is you're trying to divide the vitreous which is prolapsed into two segments. First, position the cutter below the level of the posterior capsular tear with the port facing down and cut all the vitreous which is beneath it. So by this you're trying to transact the attachment between the one which is prolapsed and which is behind the level of the posterior capsular tear. So once you start with the port being posteriorly, and then you turn the posterior sideways, and lastly you turn it anteriorly, then only the cut and prolapse vitreous is then removed out. By following this principle, you are having a higher chance of preventing the enlargement of the PC tear in spite of going through the translimbal route. And of course, last, the rhexis. If you can do a posterior capsular rhexis, then you definitely have significant advantage. Now, you've got two circles here. One is the posterior capsular tear, one is the anterior rupture. So both of them have ruptured in this situation. So as I fill OVD, you can see the vitreous trying to gravitate towards the side port. It is indicated by the distortion of the capsular tear, clearly suggesting that the vitreous has found its way to the side port incision. Now, what do you do now here? First, obviously, you're going to stain it. And first I begin by just cutting the vitreous at the wound itself. And remember, at this stage we are not even gone enter the chamber. So preferably first, because the chamber is now maintained with the dispersive OVD. So what I do is first I go in with the cutter. Now not much of a cutting is happening, Once it goes, and after few cuts, then only the chamber, the infusion enters in, and the bottle height, remember, it is as low as 20 or 25 centimeters. Look at the position of the cutter there. The cutter is positioned, the port is faced downwards, and first you do a little but limited vitrectomy, and once the fluttering of the margin is an indication whether the vitreous is still present in the vicinity or not. So once, if there is no vitreous, the fluttering starts to appear, that is a sign that you have taken care of the vitreous around the tear. All this is happening in very, very gentle environment. There is no turbulence at all. Okay, if you have higher infusion pressure, it's going to rip open it. So once you're done that, then you're going to turn the port sideways and then anteriorly. And at this stage, after doing vitrectomy, it continues to remain the same, tear. Then you're going to do a PC tear, the rhexis. The advantage of doing rhexis is that while implanting your lens, the tear does not enlarge. That's the reason why we have to do it. So, to summarize it, always maintain, never allow it to shallow. You have got higher chances of decreasing the rate of PC tear enlargement. Use low bottle height, that's important. And third would be, position your port appropriately. So this is one thing which is not highlighted, the infusion pressure. People forget to just lower it as you start doing vitrectomy. And if you just, it blows open. And the position of the port is something which I'd like to take a note of. Start by making it posteriorly. And of course, you are going to use the highest rate and the lowest flow rate and vacuum. Basically, you're trying to do it in the least turbulent environment. Just it's cutting. And lastly, the last part is the one which you're removing anteriorly. Now, this is a care where, again, you have posterior capsular tear, anti-hyaloid rupture. In this case, I'm trying to do a PCC before the vitrectomy itself. You have a higher chance of success of, getting PC tear. The problem is, vitreous cannot be there. You have to push it down. Then only you can achieve a posterior capsular rhexis. Once you have a posterior capsular rhexis, the chances of the PC tear enlarging is much more lesser, okay, significantly lesser. And we have a nice rhexis like this. You always have got a chance to place the same lens in the bag itself without any issue at all. So I think with these messages, I'd like to conclude my talk. And I'll request Dr. Shail to start his presentation now. Thank you so much for your attention. Got questions, you can just write down. At the end of the session, if you have this thing, we'll discuss.
Thank you so much, Dr. Megur, for making me part of this extraordinary course, and I think everyone will agree that it will be probably impossible to find better videos than what he and his team can show. So thank you so much for the excellent videos and the excellent teaching pearls. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. I think any of us who operate are going to encounter this situation where the capsule ruptures and the vitreous is staring at your face. So the most important point, irrespective of what you do later, is to prevent this from enlarging further, which means inject from the second port a dispersive viscoelastic. And here, like Dr. Megur mentioned, why is dispersive important? Because dispersive will stay there. It will tamponade the area. Unlike a cohesive viscoelastic, which comes out easily in one bolus immediately. So inject a viscoelastic, and however experienced you may be, there is no other sign of identifying vitreous except for using diluted preservative-free triamcinolone. Like in this case, if you'll notice here, everything, all of the clinical signs that we have been taught of are perfect. The pupil is round in shape, there's no distortion of the pupil margin, no peaking, and still there was a vitreous strand which was extending from the PCR right up to the side port incision. So do not swipe the wounds, but always look for the presence of vitreous by injecting diluted triamcinolone. And the next question is, when do I do vitrectomy? It's a very simple answer. Whenever you notice vitreous disturbance, it could be right at the beginning of surgery, it could be with 3/4 of the nucleus inside, it could be just before IOL, or it could be with cortex inside. So until you tackle the vitreous, once you identify it, do not move on to the next step. And we'll come to why is that important. The goal of vitrectomy is we need to understand the goal. The goal is to prevent acute intraoperative vitreoretinal traction. Because what the traction that we are going to cause intraoperatively is going to determine the long-term health of the eye. We may satisfy our ego that, I prevented it from dropping, I could put the lens in the bag, but the patient develops RD 3 months later or glaucoma 4 months later. So it's the intraoperative vitreoretinal traction that you do during surgery that is going to determine the long-term fate of the eye. So there should never be a trend, we don't want to salvage the nucleus at any cost. This is a very basic but very nice animation to show that you have an anterior capsule split in this case, and the nucleus is showing, is just gone behind the anterior posterior capsular tear, and you think it's just there. Let me go and grab it, let me go and do something about it and get it there. What we don't realize is by making these maneuvers, the traction that we are causing at the vitreous base as well as at the macula. And these are the things that lead to giant retinal tears, cystoid macular edemas post-operatively. So best is if the nucleus drops, the simplest technique is what we describe as the bye-bye technique. Let it drop, do a good thorough anterior cleaning of the anterior vitreous, and let the vitreoretinal colleague take care of the drop nucleus. This is a video I borrowed from my vitreoretinal colleague at our institute showing a subluxated, dislocated cataract, and notice the amount of vitreous adhesions that are there around it. This is something that we don't normally see with our naked eye, and we just feel that there's just one fragment, let me grab it. So it's very important that you remove the traction or the attachments of the vitreous before you handle any fragment or anything else. The secondary goals of vitrectomy are to prevent further enlargement of the PCR, do an adequate vitreous removal, and provide a symmetrical uniform scaffold as much as possible for an IOL implantation either in the bag or in the sulcus. Irrespective of the type of vitrectomy, we do limbal, pars plana. This is the principle which we must always follow. Never perform dry vitrectomy. So you must always have fluid coming in either from the limbal route or the pars plana route, and do not give up the habit of using sponge to identify the vitreous and cut with the scissors. When you apply a sponge, it causes tremendous traction from where the vitreous is coming from the vitreous base. So these are two important principles to keep in mind. And always do bimanual vitrectomy, which means separate the irrigation from the vitrector. So even if you have a machine which has a coaxial irrigation aspiration for cortex removal, for vitrectomy you must have a bimanual system, which is the irrigation and the cutter should be separate. Now, which approach to choose, limbal or pars plana? I think each has an advantage and disadvantage one over the other. But the take-home message, whatever technique you use, is adequate vitreous removal has to be done, whatever technique you are comfortable with. The advantage of a limbal approach is that it's something that we are all used to, working from the limbal area through our side ports, and that is how we have been, that is how we have learned, all of us as cataract surgeons. The major limitation of limbal vitrectomy is that when you drag from above, you are dragging a larger amount of vitreous body from coming, and generally the posterior capsular tear enlarges. But I really appreciate Dr. Megu's previous presentation showing tricks on how to prevent that from occurring even from the limbal route. This is a high-speed photography to show the same, that when you are doing limbal vitrectomy, here the port is facing up, there is significant drag on the vitreous, and you'll see the margins of the capsular tear enlarge. But even if you turn your face down through the posterior capsular tear, you are dragging on a much larger base or a larger chunk of vitreous, which causes a lot of turbulence and quite often causes turbulence at the capsular tear margin. Coming to the pars plana approach, we always find it intimidating that we are not retinal surgeons, how can we enter through the pars plana? And do I need separate machines, separate instruments, so on and so forth? So fortunately, not much is needed. The major advantage is that because we are draining it from where it is actually coming from, we are actually attacking a much smaller amount of vitreous than or what is only required, and therefore the chances of enlargement of the PCR are lesser than a limbal approach. Notice this again, the irrigation is through the limbal approach, the vitrector is through the pars plana, and very minimal turbulence occurring at the edges of the posterior capsular tear. Like Dr. Megur showed very nicely how to approach it face down, the only limitation with the limbal is in spite of changing hands, there's the ergonomic access is generally limited, and therefore there are chances of leaving behind unequal pockets of vitreous around the area of the PCR, which may lead to some tilt of the IOL in the post-operative period. Compare that to the pars plana approach, where the ergonomic access is much easier. So you're just moving your right hand, and remember it's only 3.5 millimeters away from where you're already working. So it should not be too much of a big deal. How do we approach it, and how do we start doing a pars plana vitrectomy? The first thing to know is where to make the entry, and for that basic anatomy is important to know. And generally for an adult eye, somewhere in the region of 3 to 4 millimeters is the area of the pars plana. It varies, of course, based on the axial length, based on the corneal diameter, so on and so forth. But generally for an healthy adult normal eye, it's somewhere between 3 to 4 millimeters from the limbus. And generally we use a standard cutoff of 3.5 millimeters from the limbus. So you can use a caliper to measure 3.5 millimeters, mark it from the limbus. And what we typically like to do is to do a single plane entry but make two incisions, which means I'm first lifting up the conjunctiva so that my conjunctival entry is different from my scleral entry. So when I bring out my trocar, the two should not coincide, and therefore sealing will be better. So I'm lifting up the conjunctiva, just making a subconjunctival entry, then turning the trocar down, and the direction has to be as if you want to go and hit the optic nerve, which means you want to go vertical and as if you want to go and hit the optic nerve. That will never happen. But if you try to turn it sideways, you may end up going through the posterior capsule. So this is how you generally make it. Now with the newer generation trocars, you have markings even on top of the trocar, so you need not necessarily have to even do a caliper marking. But what's most important is that you want to make sure that the chamber is adequately formed before making the pars plana entry, because if it is not, it can collapse. Like this eye, fortunately, we did not require to take any sutures before making the pars plana entry. But in most eyes, I would certainly recommend taking a suture at the main incision, even if it may be just a 2.2 millimeter incision. Just take a suture so that if the chamber is formed properly, it will be easier to make a pars plana entry. Another important point is when you remove the trocar, there is a tendency of a wick of vitreous coming in the area of the trocar. So you must be ready with the counter traction. So immediately as soon as you remove the trocar, this is what retinal surgeons recommend, a blunt instrument to just tampon at the area from where you have removed the trocar and massage it so that there is no strand of vitreous that is coming out. Now you need to know, if you don't have access to trocar, if you're scared of using a trocar, simplest is to use your lance knife or your same MVR knife or your side port knife. You generally have to do a conjunctival peritomy, because doing transconjunctival will lead to ballooning of the conjunctiva as soon as you go in and out of the incision. So do a conjunctival peritomy and then use the same lance knife to make a 3.5 millimeter incision, 3 to 3.5 millimeter away from the limbus. The only drawback would be that you need to suture this wound after you've finished up all the vitrectomy, because this would typically be a 20 gauge vitrector which would not self-seal. So you can easily suture the conjunctiva as well as the port. What gauge of vitrector? I think smaller is better, but most cataract machines are still equipped only with the 23 gauge systems. So we don't get cataract machine cutters more than 23 as of now, but I'm sure it will increase with time. So smaller is better, and 23 and beyond is usually self-sealing. What are the optimal parameters for pars plana vitrectomy? And that is, I think, it was very nicely highlighted by Dr. Megur previously. That one is you want to keep your irrigation low, which means either the bottle height or the intraocular pressure low, somewhere in the range of 20 to 30 intraocular pressure. A very low flow rate. So I'm keeping a flow rate of only 15 cc. So I don't want too much of attraction coming up. and a vacuum appropriate depending on if you have had to use too much of viscoelastic injection, you may need initially a higher vacuum, but generally a vacuum of around 250, 300 is enough. And go for the maximum cut rate that is there on your machine. It could be 1500, it could be 2000, 2500, whatever it is. Here in this case it's 4000, now with the upgraded software it's 5000. But whatever the maximum cut rate that your cutter offers or your machine offers, put that as the default setting. So just a couple of cases to highlight the role of pars plana. Yeah.
One more minute.
Yeah, sure. So this is a case where 3/4 of the nucleus is inside the capsular bag, but I've noticed a large PCR. So whenever you notice PCR, you must confirm whether vitreous is present or not, and sure enough, it was present. And therefore, we need to tackle it before I look to tackle the rest of the 3/4 of the nucleus. A good anesthetist will always help. They may bump up the, and look at this pars plana drained nicely. That vitreous that was there, it got sucked in beautifully through this PCR that is there without causing an even millimeter of turbulence in the area of the PCR. And now since we have cut off the connection between the anterior and the posterior compartments, we can go ahead without the fear of dropping this nucleus with phacoemulsification, with low parameters, low flow rate and low bottle height. Because this tear was extending up to the equator, the choice of IOL, of course, was a 3-piece IOL with optic capture. Most of these patients do very well post-operatively. And even in the end, make sure that make sure that there is no vitreous disturbance in the end. So I'd like to end here, and the most important take-home message that I would like to share is, irrespective of whatever technique you are comfortable with, doesn't matter, limbal, pars plana, one may have a slight advantage over the other. The take-home message should be, vitreous needs to be tackled. It needs to be tackled adequately from this route or that route before going on to the next step. And diluted triamcinolone acetonide is something that all of us should have as a backup in our ORs so that the assistants don't have to scramble to find it. Thank you once again for the patient listening.
Thank you, Shail, for the extraordinary presentation. Very nice. Thank you for teaching us all the basic principles of pars plana approach. And I request Dr. Saurabh to present his presentation. He'll be speaking on how to implant an eye, an IOL in an eye with PC tear. He'll be sharing his pulse. As he's setting it up, just like to highlight that when you're trying to make a pars plana incision in a PC tear eye, the eye would be very soft, okay? So just take home message would be, refill the eye with viscoelastic, suture the wounds as was demonstrated by Dr. Shail. So never try to poke in with your, also forget that, during this incision, we may end up causing trauma there itself. So be mindful of that. Are you ready, sir? And second important message, what he shared with us is that, you don't have to have a trocar cannula as well. You can very well do a conjunctival peritomy, measure 3 mm from the limbus, and then do your MVR blade. Go in and come out. When you enter also, don't go in with your cutter on when you're going inside. I think that has to be inside. You do an initial cutter and then you go in, and then you should visualize your cutter behind the posterior capsule before actually start cutting. Because you should know where your positioning is. And obviously, if you have to use the MVR blade, even if it's a 23G cutter which I've used, I would still recommend it to be sutured. Because I would be soft after doing vitrectomy, and there is every chance that...
Hello.
Okay, you can start.
Okay, good afternoon everyone, and thank you Dr. Deepak and Dr. Bharti for the invitation to speak in this course. And I'll be speaking on IL after PC rupture. I think what is the most common mistake that we all do is that after PC rupture, we feel that we are operating on the same case that was presented to us. I think psychologically that is the mistake, because what I found out in my earlier days, when my trainee or fellows do complication, I manage it much better rather than when I myself get a complication. And that's because we are still in that past, I am operating on a normal case. Once we have a PC rupture, just think that you are operating on a brand new case. It's not the case you started with, and then you may approach it in much better way with clearer thinking. So what is the thought process once we have a PC rupture? about the IOL, which IOL we are going to put and how we are going to go forward. So we have to ask ourselves two questions. Can the remaining pieces support the IOL in the bag? Is the anterior CCC intact? Is the sulcus intact? Are the zonules strong enough to maintain that sulcus? If either answer is yes, then we can either plan IOL in the bag or we can plan IOL in the sulcus. If the answer for both these questions is no, then we have to go for a iris fixated or SFIL. So part 1, I will deal with, in case of PC rupture, how to place IOL in the bag. Now the question is, when we have the standard procedure of putting either a 3-piece IOL or a PMMA IOL, which we can easily put in the sulcus, why to take all these risks and put IOL in the bag? Now sometimes we don't have better options. For example, patient has opted for a premium IOL like multifocal EDOF or a customized IOL like toric. Then it's always better from patient point of view if we can place these IOLs, because these are made only to be placed in the bag and not in the sulcus. So let's start thinking when we can put the IOL in the bag despite having a PCR. So first thing we have to judge what is the status of anterior hyaloid and what is the status of vitreous. Okay. So sometimes there may be a PCA rupture, but anterior hyaloid may be intact. In such cases, you can place the IOL in the bag without doing much. Of course, I will show a few videos later. But whenever there is vitreous in the anterior chamber, always do antivitrectomy. I think already emphasized by previous speakers. Sometimes what we do, we use maybe OVD or heavier OVD to push this vitreous just aside, place the IOL in the bag, and we feel that it's all going to be fine later. But what happens over a period, the IOL is going to get decenter, vitreous is going to prolapse, and patient is going to land up with more troubles. So don't do that. If there is vitreous, remember you have to remove it before even thinking of putting IOL. So what is the exact requirement for IOL in the bag? We just need to support the haptics and the optic-haptic junction. So if you see the posterior capsule, the central part of the PC is in fact not critical for IOL placement. So if you have a horizontal PC rupture in the central part, you can just place the IOL vertically and it's going to be stable over the long period as well. Same with vertical rupture, you can place it horizontally and it's going to be stable. What happens if there is small peripheral PC rupture which is much smaller than the optic size, you can still place the IOL in the bag. But if you have a large peripheral PC rupture, or you have a PC rupture in the periphery in the inferior part, I think the gravity and with the capsular fibrosis, even if on table the IOL may look center, it is going to decenter and cause problems. So in such cases, avoid putting PCIOL in the bag in case of PC rupture. Now other thing which we can do with large peripheral PC rupture is that we can do anti-optic capture in some limited cases. When when there is a lens which you have to put. So remember, there are certain lenses which are suitable for placing in the bag even when having a PCR. But if you have a plate haptic design or a 3-piece IOL, when there is a PC rupture, avoid this because it is going to stretch the PC further and you may have a extension of that PC rupture. But these kind of IOL designs are more suitable for placing in the bag despite having a PC rupture. Of course, when the first conditions are met. So I just want to show you a little mistake. So here there is a PC rupture, anterior hyaloid is intact, so I am trying to make it into a posterior capsular axis. Now the most important principle while doing that is to keep the anterior chamber well maintained. Now here I am not doing that, and what happens is that the anterior hyaloid starts prolapsing and the vitreous gets disturbed. Now the only way to go forward is to complete the antivitrectomy as I said, and then only I can place the IOL in the bag. I could have avoided this if I would have maintained the anterior chamber while I was making the posterior capsular axis. Once it is done, always use 2% methyl cellulose. Don't use any other because it's easier to wash out after you put the IOL. Don't use heavy dispersive OVDs. Now, second thing, what I did just now is I enlarged the incision slightly because after vitrectomy, eye is little hypotonous and you don't want to struggle putting your injector. Okay, so slightly enlarge the incision so your injector can easily go in. Keep the second instrument, you can see below the optic, always target the direction of IOL insertion at the angle of the iris and not into the sulcus or into the bag, okay, because that is to avoid sudden drop of the IOL into the vitreous. So So always target it towards the angle of the iris. That means you are going to try to put it in the anterior chamber first. And placing the Sinski below it will help avoiding this problem. Now once it is in the anterior chamber, you can use gentle manipulation, you can use bimanual manipulations also to place these haptics into the bag so that there is no undue traction on the posterior capsule and the IL remains well stable after. And always, this is another tip, always what I do is I just wash off this 2% methyl cellulose just with jets of BSS. I generally avoid using coaxial IA or bimanual IA because when you use that there are fluctuation in the anterior chamber, there might be again vitreous prolapse or IL may decenter. So just wash out, and methyl cellulose, it's very easily washed out by just jets of BSS. If you have access to Centurion, you can just keep 20 IOP and then do the same thing. But this still works better because when you take out IA probe, always there is a AC collapse and there will be again some issues which might be forming. So I just wash off this carefully. Now you are not very confident of converting a PC tear which is central into a CCC. No problem. If the anterior hyaloid is intact, then you can again do the same maneuvers, very gently place it in the bag, and as I showed, the trick here is to wash out that methyl cellulose using just jets of BSS. You may take 4 or 5 minutes to wash out all the methyl cellulose, but that works wonderfully well in these cases. Now second part is about placing the IL in the sulcus. Okay, so first part we just finished. Second part is where the PC, as I have shown, the first 3 conditions are not met and there is a large rent which is going to the periphery and I have to place the IL in the sulcus. So now I have to pre-plan whether I am going to place it in the sulcus with optic capture or without optic capture. Why it is important? Ultimately, even if case of PC rupture, we want to give the best refractive outcome to the patient. A patient after PCR, if patient has unaided 6/6 vision, he is going to be happy. But if he has residual refractive error, he is not going to happy. So what is the ideal case where you can do optic capture? A CCC should not be more than 5.2. Ideal is 4.8. So if you have a PPC case, I always target for 4.8 millimeter central rexis. Why it is important? Because if I am not going to do optic capture, I reduce the IL power by 5%. If I am going to do optic capture, I just keep the same emetropic IL power which has to be placed with optic capture. Now certain important steps when you are going to how to achieve this optic capture. I will just fast forward it. Okay, so tips is use adequate incision. I already said open the IOL in the AC, don't try to directly put it in the sulcus. Then always push these haptics very close to the iris. So it's not like dialing a IOL in the bag. When you dial these haptics, it has to actually literally touch the iris and then you are sure that it is going to go into the sulcus and not into the bag by mistake. Okay, so just to show, now the IOL is in the anterior chamber. I am going to dial these haptics inside and just watch. When I dial, I make sure that haptics are actually touching the iris while they are going into the sulcus to make sure they are not going anywhere else. This is more important when you have a larger CCC where you might be little doubtful about the CCC margin. It's always a good idea if you have a small pupil to use iris retractors before you inject the IL rather than struggle with visualization. The next tip is when the CCC is centered and you want to tap, remove the OVD or if there is a vitreous behind the IL first before you do the optic capture, because once you do optic capture, the whatever OVD is trapped behind is going to stay there and may give rise to a little bit of raised IOP or inflammation post-operatively. So if possible, you remove this OVD behind the IL first if you are comfortable with that. The end point of optic capture is to have a spindle shape configuration. Just watch here. I have done optic capture here, but it's not yet spindle shape. You can see it looks as if it is a square. Once I tap it down, now you have a proper spindle. So there has to be spindle with the apex at 2 optic haptic junction. That means now the optic capture is complete. Now the surgery is not complete until you finish and close the chamber. So sometimes what happens afterwards when you try to wash the visco, there might be AC shallowing and the optic capture may get disturbed. So that means one of the side of the optic may come in front of the anterior capsule, and that is more problematic because then it leads to IOL tilt in the postoperative period, again a poorer refractive outcome. So always before you finish the case, make sure that both sides the optic capture is already there. So these were a few tips from my side about using PCR after PC rupture. Thank you.
Thank you, Saurabh, for teaching us so well about and sharing us few tips about IOL implantation in eyes with PC tear. Now, may I request Dr. Rohit Om Prakash sir to speak on how do you manage when we have a PC tear with an overlying nucleus?
Thank you, Dr. Deepak, for the opportunity. So I'll be taking up PC tear with an overlying nucleus. Can we FECO? This was what was asked by Dr. Deepak for me to speak about. Well, the primary objective of when we have a PCR is to have a safe and thorough cleaning of lens fragments. And the secondary objective is do an IOL implantation. Now let's see some scenarios where there is a pre-existing PCR, like patient with anti-VEGF multiple injections. So this patient had repeated anti-VEGF injections. Visual acuity following last injection increased from 6 by 32, 6 by 36 to 6 by 18 and then dropped to finger counting in 2 months' time. So we did we did a pre-operative OCT and realized that there was a PCR. Now the question was whether we should go in for an anterior approach or we should go in for a posterior approach. Well, with the new machines and new fluidics, we went in for the anterior approach. So the strategy was to use low IOP settings as has been propagated by Bob Osher and Abhay Vasavda. Consider the patient as a posterior polar cataract with pre-existing defects. Use flax if possible. Sizing of rexes, as Dr. Saurabh has said, should never be more than 4.8. Hydro procedures should be avoided. Rotation should be avoided, and chopping techniques have to be customized. So now let's see this patient. You know, in this patient, a 4.8 millimeter capsulotomy was done. Calibrated side port incision was given. Capsulorhexis was completed. The fluidics you will find is with around 20 IOP pressure. With this 20 IOP pressure, the bottle height is around 28. The aspiration rate is flow. I'm going around sculpting with the slow motion concept because I do not want to overinflate the chamber, which I've been able to do with less IOP. There's less infusion of pressure. The nucleus is being separated completely. Once this complete separation of the nuclear fragment is done, I know that the posterior, the capsule is going to be, exposed to it. So this low IOP is helping me because there is less amount of fluid which is being infused into the anterior chamber. There is less posterior bulging of the posterior capsule, as has been shown by Vasavdas, that with an intact capsule, you can have an anterior hyaloid phase rupture if you use high fluidics. So this low fluidics is helping me create a situation wherein I am not letting any vitreous phase to be broken whatsoever. I am doing slow motion phacoemulsification at the level of iris and slightly anterior to it because I knew that it is a soft cataract and the process is being continued without any problem whatsoever. This is only possible if you are able to create a situation wherein you have stable chamber settings with these fluidics. Usually with the active sentry and everything, with all these active fluidics, there is least amount of fluctuation in anterior chamber. You can see the side port incision which I am using is also very important because stable chamber settings are very important. With the femto delineation, I have kept away the posterior capsule also. I am using a coaxial one with a slight modification. I have retracted it. With this retraction, I have tried to create a situation wherein the irrigation and aspiration have different level of flow, and this is being done. And this femto delineated, this epinucleus or the nucleus, the posterior nucleus is now being aspirated. And since it is being done, it's difficult at times, so it is going around with a very slow pace. And I'm trying to just, stuff it in so that I'm able to do, total aspiration of the posterior part of the epinucleus. Once that is done, I implant an intraocular lens which in this case would be a three-piece. I did not venture into going in for a single piece and do reverse optic capture, because I thought that I was not comfortable at that point of time. But this is an option which I would definitely go in for, keeping in mind that the capsular axis size was small, and now I am doing the optic capture. So you can see how with a posterior capsule rupture you can go ahead with low fluidics and complete emulsification, and this is triamcinolone coming into force and showing the absence of vitreous whatsoever in the anterior chamber. So this is another patient wherein there's a posterior polar cataract with pre-existing posterior capsular defect. In this patient, anterior segment OCT is very important. Low IOP settings, low motion phacoemulsification, stable chamber settings, sizing of rexes, no hydro procedure and chopping techniques as I have already shown. So let's see this video. In this video, you will find that there's a 41-year-old lady who had bilateral posterior polar cataract. High expectations were there. This is a moth-eaten type of posterior polar cataract. You can see the posterior posterior capsule is not intact. Visco is being no overfilling of the anterior chamber. Calibrated side port incision. Rexis of my choice is the oval rexis, as shown by Kiranjeet Singh from Amritsar. This gives the advantage of both a small and a large rexis. So now I'm starting with sculpting. The IOP is 26, which I will gradually reduce. I'm continuing with sculpting, and the moment I sculpt, I find that I have reached a situation where it is neither soft nor it is hard. And when I'm trying to separate it, I'm not able to separate it. I try to do cross chopping. I'm not able to do that. So in this situation, I'm just trying to debulk it and use the the escape route, as Bob Osher always says. So I'm trying to create a situation where there is now I'm trying to do that is the escape route. Now what is the next thing which I am doing? I am trying to do centripetal dissociation of the nuclear fragment. So this is being done in a low guarded manner. I can see the posterior capsule has given way, and it is a very tricky situation. IOP has been further reduced by me to 24. I'm going around with us in a slow motion manner. Stable chamber settings are being applied. And now what is the next thing which I'm going to do? I'm going to do visco separation. This visco separation is going to be done so that I'm able to separate it from all sides. So I'll try to separate it in the sub-incisional area also. Once that is done, I have a free floating, epinuclear nuclear mass, and then with, slight repositioning of the nuclear fragments, of the last nuclear fragment, I'm trying to reposition it, and you can see how I'm able to do it. Once that is done, with this low IOP, wherein there is hardly any difference it's a physiological IOP totally, low fluidics whatsoever, a nucleus floating, not being pushed behind, with the visco and the low fluidics, I'm able to complete emulsification by totally dislodging it from the periphery. Once that is done, you will find that emulsification is complete in a very slow motion manner. So you can see now it is being completed. Now once that is completed, I'm using stable chamber settings. Next, what I'm doing is I'm doing the Gills-Welch dry aspiration. In this, the steps are irrigation, aspiration, fixing, teasing and stripping. You use a 25 gauge cannula, and then I'm visco expressing it out. So you could have used a bimanual also. Triamcinolone being used, and you will find there is hardly any vitreous disturbance in this patient. And once that is done, I can easily implant an intraocular lens. I am using a 3-piece intraocular lens in this situation, and I'm going to do the optic capture using the smaller rim of the an oval rexis, and you will find that it is complete, spindle shaped as Dr. Saurav has shown. Triamcinolone again, and you can find now that the case has been adequately completed. This is the post-op day 1. and the patient was very happy. Take home points: anterior segment OCT, low IOP settings, use slow motion phacoemulsification, stable chamber settings, sizing of rexes, oval rexes or a small rexes, no hydro procedure, no rotation, chopping techniques to be maneuvered. Thank you very much for your kind attention.
Thank you, sir. Thank you for teaching us so well. We have got 5 minutes exactly for some question and answers. If you have any questions, and we can have a discussion. If you are here already now, let me continue with this. I think, you know, the beauty of the surgery which you showed was you never allowed the chamber to shallow at any stage, every stage. And, you know, if you can follow these basic principles, you can prevent anterior rupture even in a case where the posterior capsule was open from the beginning of the surgery.
Yeah, with this stable chamber settings, you know, and low IOP, the anterior hyaloid phase doesn't become your foe. It becomes your friend. The nuclear fragments, they go,
And
they hit it, and they come back. So, but that is the beauty of, you know, using these low fluidics. As you know, this was, yeah.
No, sir, actually what he did was anterior capsule rupture. What Dr. Rohitam Prakash just showed was optic cap, because if you have a end-to-end equatorial extension of the posterior capsule.
I'm talking of another situation in which I had
It is not on.
the lens and trying to do a posterior capsular, putting the optic behind. So is it safe without the rexis?
No, if you have a rexis, then only it can hold, otherwise it cannot. If you have an irregular edge, even if it is small, when you try to push the lens behind, it's going to extend.
For any kind of optic capture, 3-piece IOL is the IOL of choice. Even for a posterior capture, if you have a single piece, because the optic haptic junctions of the single piece are very broad, so it is not possible to posteriorly capture a single piece IOL. So if you have a plan of an optic capture, 3-piece IOL design is of choice.
In children, he does, you know, double. Dr. Shell.
If you have a PCCC, you can capture even through the posterior capsular axis. We do that more in children to prevent visual axis obscuration. But it has to be a PCCC, not a PCR.
I think the take-home message is, I think, as cataract surgeons, we cannot do any cataract surgery without having a functioning anterior-vitrectomy unit and your functioning and sterile cutters. So you cannot put any lens when you have a PC tear. You know, you cannot put a blanket on yourself and say vitreous is not there. I think you need to have every tool ready, and then only you proceed with surgery. Because most cataract surgeons are so phobic to performing anterior vitrectomy. They would have a machine, they would not have opened for months, and still they just push the lens in. The problem is not with the lens, the problem is not dealt with the vitreous properly.
And another point which the take-home point, as has been shown by Dr. Saurabh and all, whenever you do vitrectomy, you have to suture them up, and the way he applied, you know, that trypan blue to see whether there is any leakage or not. Because if by any means, if there is any leakage, that can be catastrophic. So all incisions have to be, you have to be totally sure that they are totally sealed.
I think with no questions, we're in time, and thank you all speakers and the wonderful audience for the show. Thank you so much.